We know that periprosthetic infection still remains one of the first three reasons for failure of implants in orthopedics and traumatology. And this may hit poor people as well as royals, people with main risk factors, but also people who maybe have no clear risk factors. Every time we put an implant in the human body, immediately bacteria that eventually are present start to colonize the implant and start building up a biofilm that protects the microorganism both from host-immune system and from our systemic antibiotics. Once biofilm is established, it becomes very difficult or nearly impossible to remove the bacteria. But what maybe not everybody knows is that biofilms are built up in few minutes or hours. It is not a process that takes weeks or months, but only few minutes or hours. And in 24 hours, a biofilm is completely formed, and only it goes through a process of maturation. It becomes more organized. But bacteria starts building up the biofilm immediately after adhesion on a substrate. So we know that implant-related infections are a problem because they are biofilm-related infections. And we have to change our point of view and not only consider biofilm as a problem, but also as a target. And this can be a target for diagnosis, for prevention, and treatment. We now will focus on prevention. And if we understand well the pathogenesis of implant-related infections, we must change our point of view also as to regard the prevention of implant-related infections. The idea of transforming our passive implants in something that is active and that is protected by bacterial colonization is something that many centers around the world are actively studying. This is a paper that came out last year from the University of Stanford in California, where these authors, both orthopedics and bioengineers, concluded that the most needed implant coating technology today relates to the prevention of and treatment of deep infection. And this also is the opinion that was assessed during the consensus meeting in Philadelphia last year, in which more than 3/4 of the experts that were present answered positively to the question if there is a role for modification of the prosthesis surface that may minimize periprosthetic joint infection. The problem is that in front of this need, available coatings suffer a lot of limitations that prevent their spreading. And these limitations range from the cost issue, from the regulatory issue, from the possible longer-term toxicity, and to the possibility of being used on any implants. One possible technology that we have been studying since many years now is that of applying locally a fast resorbable hydrogel that is mainly composed of hyaluronic acid with a small percentage of polylactic. And this is a complete change of paradigm because instead of looking for a long-term prophylaxis, we are looking for a short-term local prophylaxis, very much the same as it is done for systemic prophylaxis. This idea was funded by a big grant from the European Community, and this is the partnership around Europe that contributed to developing this idea. And these are the 6 research centers that provided preclinical important studies to support this idea. In this research, it was tested the safety of the hydrogel, the physical and chemical stability, the possibility of sterilize the device, and to obtain a shelf life that was compatible for a clinical use. Secondly, the hydrogel that comes as a powder in a prefilled syringe was tested as to concern its ability to deliver locally antibiotics and antibiofilm agents. This has been published recently in Clinical Orthopedics, and I will briefly go through the main results of all these studies. First of all, it was tested that the hydrogel is able to deliver locally a large number of different antibiotics at a concentration ranging from 2 to 10%. The local delivery is completed within 72 hours. The hydrogel does not interfere with the antibiotic activity, and it may have a synergistic activity that has been shown with some antibiotics. So the MIC of the antibiotic to the antibiotic is reduced in combination, when used in combination with the hydrogel for a number of different antibacterials. Also, it was possible to show in many experimental sets and on different substrates with different strains the antibiofilm activity of the hydrogel with different antibiotics, as you can see here. Also, it was tested the ability of the hydrogel to resist the introduction of an implant in a press-fit mode. And this was tested in animals with a cylindric shape, and in human cadavers with a normal press-fit cementless implant, in which it was shown that most of the hydrogel, approximately 80%, remains on the surface of the implant, and the rest remains in the inner part of the femur. In vivo testing was performed in Rizzoli Institute of Bologna and in the University of Utrecht in the Netherlands. And these are the results from Bologna, in which, in an animal model, it was tested with a high inoculum, the acute reduction of bacterial load that was up to 99% compared to controls at 7 days after surgery, with a complete abolition of septicemia that instead was present in all controls, in spite of systemic antibiotic prophylaxis. And this is the result. These are the results from the University of Utrecht that have not been published yet because they are very recent. They have been communicated in the last European bone and joint infection meeting with a high inoculum, no systemic antibiotic prophylaxis at 28 days. Here you can see, in comparison with controls, they develop infection in approximately 90% of the cases, while treated animals, they do not develop infection in approximately 90% of the cases. The difference is highly statistically significant. This is the first demonstration that the local short-term prophylaxis is highly effective in preventing periprostatic infection. And if we look at the bacterial load in those implants that were protected by the hydrogel with antibiotics, the bacterial load was very, very low compared to the animals that were infected and acted as controls. Of course, blood tests, they were all in line with this histopathology at 28 days, very, very high statistically significant difference. But most importantly, it was tested the osseointegration. The gel does not interfere with the osseointegration in this animal model. And now we have micro-CT studies, and it's very, very interesting. And it was tested with no infection. You see no infection, no hydrogel. You see bone formation with this fluorochrome in red at 7 days, bone formation, and in green, bone formation at 21 days. Here you see no infection, no gel. No infection with the gel, no interference with bone formation. No infection, gel and vancomycin, 28 days, good bone formation, no interference. But what happens with the presence of infection? Infection, no gel, no bone. Infection, gel, with this high bacterial load, no systemic prophylaxis, no bone formation. But if we administer gel plus vanco, here what happens? Nearly normal bone formation, and here at 5%, different concentration, bone formation. CE mark was obtained at the end of last year, and now we have approximately 1 year experience. Here, what you need during surgery, the hydrogel, the antibiotic, and sterile water for injection. Here, how it works, it takes approximately 3 to 5 minutes to prepare the gel. Here, the prefilled syringe that, through this easy system, is mixed with the antibiotic of your choice. We have treated patients also with 2 antibiotics. You can do that if you like. And after approximately 20 movements like this, the gel is ready and can be applied to the implant in this way, and the implant is then inserted in the usual way. This also can be done, of course, for the stem, for polyethylene parts, and for the screws, for all the implants that you would like to protect. We have used the hydrogel coating in high-risk patients. This is a patient with lymphoma, and this is the coated implant. For patients with previously infected site, we have a number of sequelae of septic arthritis that converge to our center. This is a case of a young male. This is the preparation of the implant. I go quickly. Just to show you the results, 9 months later, absolutely no interference with bone osseointegration. And this is another similar case in a sequela of septic hip for possibly or probably infected site. Not always it is possible to be sure that a failed prosthesis is not infected, and this is a case. Negative CRP, but positive fluid, synovial fluid examination, even if with negative culture examination. The patient received heterologous bone graft in a previous surgery, and in this case, we would like to have some more protection, and we implant a protected implant. This is another case for another possibility is to use in infected site. These are patients in which we perform a one-stage procedure, since two-stage may be too dangerous. And in these cases, we can do a one-stage procedure with uncemented implants. This is another case, a very old man. This is one of our first cases. It was a contraindication to do a two-stage procedure, and we implanted a one-stage implant, and here, 1 year after surgery, you can see the bone growth. Or for patients looking for extra protection. We have some private patients that would like to receive an extra protection and they can afford this. And here the results. Or also, it is possible to use the hydrogel with different antibiotics, different than vancomycin. For example, in this patient, she reported an allergy to vancomycin, and so we used teicoplanin. And this is how it looks with teicoplanin, 5%, and here the control at 6 months. Or patients that come with a previous infection but with a known resistance to glycopeptides, in which we may use, for example, tigecycline, as in this case. Here you can see tigecycline gives this coloration. Of course, it may be used also for trauma patients, and we have a part of our study that is ongoing on trauma patients. Here, just to show you that the hydrogel does not seem to interfere with bone healing at all. These are the results on safety that we are performing as a post-marketing part of our study. And these are the report that comes from other centers. This is the center from Professor Malizos in Larissa. That is one of the centers that is working on that. These are the other centers that are working. In conclusion, we know bacteria are on the heart by more than 3 billion years. The Homo sapiens only from 100,000 years. And we know antibiotics only from 80 years. And biofilm only for 30 years. So we are very, very infant in comparison to bacteria. Bacteria are very clever. This is the map around Tokyo, and many engineers have studied for years how to connect different cities around Tokyo. But if we put a small microorganism like Physarum polycephalum, and we put it where Tokyo is, and we put rice granules in correspondence of the cities around Tokyo, you see that Physarum grows and grows and grows, and in one day it designed a map that is equal to the map around Tokyo by 95%. So, since bacteria are so clever, we need, as in Palio di Siena, here you see in Tuscany, when you do the race, everything is permitted. So we need to help our body to rig the game, to make it more fair to our host cell. In conclusion, the way to achieve coating for widespread use in orthopedics is long, but alea iacta est. And I think we are getting a little bit closer. And I invite all of you to Milan at the exposition that will be held next year and to the meeting that we are organizing on biofilm-related infection. And all of you are welcome. Thank you.